Hello, my name is Dr. Harold Bays, Medical Director and President of the Louisville Metabolic and Atherosclerosis Research Center, located in Louisville, Kentucky. I'm a clinical trialist, and I've had the privilege of being an investigator in the MariTide development program. Yes, these are really important questions. So we call it AMG 133, but otherwise known as MariTide. It's a combination of a fully monoclonal antibody to the glucose-dependent insulin-trophic polypeptide, where you also have attached the glucagon-like peptide-1 receptor agonist. And so when we talk about MariTide or MariTide BART caproglutide, what we're talking about is the tide, which is the GLP-1 receptor agonist, which is the peptide. And then when we talk about the BART, we're talking about that antibody to the GIP. This was a study, and it's been published in the New England Journal of Medicine. It's a phase 2 double-blind, randomized, placebo-controlled dose-ranging study of 592 patients with obesity and patients with the type 2 diabetes mellitus. So I'm going to answer that question, but I want everyone to understand that this is a phase 2 study, which any of our phase 2 studies help us in learnings, help us in teachings, help inform how it is we're going to conduct the phase 3 development program. But to answer your question, MariTide at the top dose of 420 milligrams every 4 weeks, so that's every 4 weeks, among those with obesity who did not have the diabetes. If you look at the placebo-corrected weight reductions, around 17% weight reduction. So robust weight reduction among those patients with obesity who did not have the diabetes mellitus. At the top dose of 420 milligrams every 4 weeks among those with obesity and who had the type 2 diabetes mellitus, there was a placebo-corrected around 15% weight reduction. And the reason that's important is because often we find in our clinical trials that those with the diabetes mellitus often do not respond as well as those who do not have the diabetes. So those with the diabetes often respond less well than those who do not have the diabetes. But here, that gap was not as great. The other thing to know is that among the patients with the type 2 diabetes mellitus, there was a 2.2% reduction in hemoglobin A1C. Less than 1/3 of the weight reduction was lean body mass. A lot of people have an interest in that. What's important, what also is very important in this phase 2 program and phase 2 study is the fact that the side effects were frequent and mostly gastrointestinal in nature, okay? That said, what I really want to get across is that among many of the patients who participated in this trial, and certainly in the patient population that had the type 2 diabetes mellitus, there was no dose escalation. The patients just got started on whatever dose they were assigned. And, you know, that's not typical in these types of drugs and the newer types of obesity management medications. Usually we have dose escalation, but we didn't do that in this case because we didn't know if it was required or not. That's why you do the study. The take-home message for medical practice would be, we have this investigational product, this investigational obesity management medication. In the phase 2 trial, the efficacy as far as weight reduction looks really good. It's once a month as opposed to once a week or once a day. And among those patients with the diabetes mellitus, it again has robust weight reduction, also robust reduction in hemoglobin A1C. So that's all great. But I think what's also clinically important is we've got to do something about these side effects because that needs to be improved. So I think the take-home message for clinicians would be this. Let's see what happens when we advance in the phase 3 program and see if a study design can be altered, can be informed by the data that we had with the phase 2 study. And let's see if we can come up with a dose escalation strategy that can mitigate some of these side effects that we see with regard to gastrointestinal adverse events. So I think that's the main take-home message. Efficacy looks really good. Need to do something about the tolerability, and hopefully the phase 3 clinical trials will help guide us as to how that might be improved. Yes, I think the area of need of most research is exactly what I talked about before, which is I don't know that any kind of alternative dosing strategy is going to diminish the potential effectiveness of this once monthly subcutaneous injectable therapeutic agent. So I don't know any kind of, if the dose escalation in the phase 3 trial is going to diminish that. But what I am hopeful is that further research is going to determine if we can come up with a dose escalation strategy so we can mitigate some of these gastrointestinal side effects.